I mean, due to the Navaratri session, everybody is away, I think. But we will have a nice, interesting session on the Adnexal mass. We heard it from the very senior person, Dr. Abraham sir. I think the PGs will be able to answer this session. This is a PG case discussion on the 27th September on Adnexal mass. Thank you very much for this opportunity, Anjalakshi ma'am, Vidya ma'am, and Sampath ma'am. I request Dr. Kausalya and Dr. Dharini to present the case. Our internal examiner ma'am is Dr. Padma ma'am, and she is a senior consultant from Meenakshi Mission Hospital Research Center, Madurai. And we have externals, Dr. Meena and Dr. Sangeeta Arya ma'am. So I request Dr. Vidya ma'am.
I think Sangeeta Arya and Padma ma'am.
Madam, no, your name is there. Meena?
Okay. Okay.
Okay. I request Dr. Vidya ma'am to address the PGs and the faculty.
Yeah, good evening. Thank you, Radhika. So we are going through yet another session of this BODHANA case presentations. So actually very interesting cases are being presented, and today the other topic also was Adnexal masses, and now that the PGs are going to present the same Adnexal mass, I think we'll all become absolutely perfect in managing Adnexal masses. So, and internal is none other than Dr. Padma, so she'll be able to bring out all the important points. I'm sure the presenter was sitting and watching the program before. Were you? Yeah, so you should be able to answer all the questions from the external. I'm sure the external was not watching. So you'll be able to answer, I suppose. Okay, all the very best to you. And let's get on with the program.
So kind of it, Dr. Vidya. Actually, when I sent this program to Sampath madam, she said, ask your PGs only to present this topic, you'll get over, she said. So that is why. So it will be like a revision. We are just finished.
Yeah, that's a nice idea actually, because it's a positive reinforcement of what you have learned actually.
That's true. That's true. So we'll get on to the session.
Yes.
So who is going to present first?
Radhika ma'am, please introduce the internals and externals.
Yes. So I have great pleasure in introducing Dr. Padma ma'am, who's senior consultant and HOD of Obs and Gynae in Meenakshi Mission Hospital and Research Center in Madurai. And she has done fellowship in gynae oncology from the Netherlands. And she is the head of the department. And she is a laparoscopic, histoscopic, and robotic surgeon. And she is a gynae oncologist, awarded Certificate of Excellence in 2023 by European Society of Gynae Oncology. And she's a member of ESGO, AAGL, IAG, ISUOG, and IUGA. Welcome, ma'am. And we have our externals, Professor Dr. Sangeeta Arya. She is ex-HOD, Department of Obs and Gynae, Banda Medical College, and Professor GSVM Medical College, Kanpur. And at present, she is a professor of Obs and Gynae at DBSK IMS Kanpur and Joint Secretary of COGS, Kanpur Obs and Gynae Society. And she's an organizing secretary of National UP COG Kanpur. And she's a proud member of the Safe Motherhood Committee of OGSI. She's presented numerous papers. But at the moment, she is in theatre, so she'll be arriving a little late. We have Dr. Meena Mahalingam, our famous doctor from Chennai, OGSI team. She has special training in Urogynae, microsurgery, and endoscopy. She's associate professor in Obs and Gynae at Chengalpattu Medical College, secretary of OGSI, co-chair Urogynae Committee of OGSI, and member of Urogynae Subcommittee for OGSI.
Thank you.
She's an master trainer of EMOC. NOC and okay. Welcome, Dr. Meena. And she's a great friend of mine and PG mate, actually. Dr. Meena.
We have done PG together and great friends too.
And yes, and we welcome Dr. Kausalya, who is a final year PG from Meenakshi Mission Hospital and Research Center, Madurai, and Dr. Dharini, MBBS from Government Sivagangai Medical College, and she is also doing a post-graduation at Meenakshi Mission Hospital Research Center, Madurai. Welcome, Dr. Dharini. So we'll start the program.
Shall I share my slides, ma'am?
Pardon?
Sure.
Just share your slides.
Good evening, ma'am. Today my case presentation is on Adnexal mass. A 48-year-old postmenopausal woman, Mrs. X, is a 48-year-old postmenopausal woman, Mrs. X, who is para 3 live 3, who had previously normal vaginal deliveries, belonging to low socioeconomic class and resident of Madurai, has come with chief complaints of abdominal distension for the past 5 months. History of presenting illness. Patient was apparently normal before 5 months, after which she had abdominal distension with sudden in onset and progressively increasing in nature. History of lower abdominal pain present, which is dull aching type of pain, insidious in onset and progressive in nature, not radiating, no aggravating or relieving factor, which is present for the past 1 month. History of nausea present for the past 1 month. History of loss of weight, which is 12 kg in past 3 months present. No history of loss of appetite. No history of vomiting. No history of discharge per vaginum. No history of postmenopausal bleeding. No history of swelling of legs or varicose veins. No history of urinary retention or increased frequency of micturition. No history of constipation. No history of dyspnea. No history of reduced urine output. No history of bowel and bladder disturbances. Menstrual history. She attained menarche at the age of 13 years of age. She had regular cycles, 30-day cycle with 3 days normal flow. No history of dysmenorrhea. Now she is postmenopausal since 2 years. No history of postmenopausal bleeding. Marital history. She is married at the age of 18-year-old. She is not sexually active for the past 5 years. Obstetric history. She is para 3 live 3 with 3 normal vaginal deliveries and sterilized after third child. And her last childbirth is 23 years. No history of usage of contraceptive pills. And she breastfed for 6 months for each child. Past medical history. She is not a known case of diabetes mellitus or hypertension or bronchial asthma or tuberculosis or epilepsy, thyroid disorders or cardiac disease. No history of previous blood transfusions. No history of drug allergy. Past surgical history. She had open sterilization done 22 years back. Family history. No history of malignancies in family members. Personal history. She consumes mixed diet, normal sleep pattern with normal bowel and bladder habits. Summary. A 48-year-old postmenopausal woman who is para 3 live 3 with 3 normal vaginal deliveries presented with sudden onset of abdominal distension and lower abdominal pain for past 5 months for evaluation. General examination. Her height, her BMI is 23.6 kilogram per meter square. She is moderately built and nourished. No pallor or cyanosis or ictus or clubbing or pedal edema. No supraclavicular or inguinal nodes palpable. Breast and thyroid normal. Spine normal. Her vitals are stable. BP is 120 mmHg in right upper limb in sitting position. Pulse rate is 78 per minute with regular rhythm and normal volume. And her respiratory rate is 80 per minute. Systemic examination. Cardiovascular system examination. S1, S2 here, no murmur. Respiratory system, normal vesicular breath sound here and no murmur, no added sounds. And central nervous system examination, no focal neurological conflict. For abdomen examination, inspection, a weight mass corresponding to 16-week size of gravid uterus, occupying left iliac, hypogastrium and right iliac fossa seen. Skin over the swelling is normal. Umbilicus in mid position. All quadrants moves equally with respiration. No sinuses or dilated veins. Hernial orifice is free. Intra-umbilical transverse scar of 5 cm present, which is sealed by primary intention. External genitalia normal. Palpation. Inspectory findings are confirmed. Abdominopelvic mass corresponding to 16-week size of gravid uterus felt occupying the hypogastrium and left and right iliac fossa, which is hard in consistency, and margins are irregular with restricted mobility in all directions. Lower margins not palpable. No tenderness over the mass. No guarding or rigidity. Inguinal nodes not palpable. Percussion. Resonant in flanks, dullness over the mass and no shifting dullness. Auscultation, normal bowel sounds here. Local examination of external genitalia. Labia majora and minora, urethral meatus normal, pubic hair sparse. First speculum examination, cervix and vagina healthy, no ulcer or mass seen, no abnormal discharge or bleeding per vagina. Bimanual examination, cervix pointing downwards, a hard, irregular abdominopelvic mass of 16 week size of gravid uterus felt more towards left side, non-tender with restricted mobility in all directions. Mass fell separately from the uterus and no transmitter mobility. Groove sign was positive and bilateral fornices fullness present. No nodularity felt in POD. Rectovaginal examination, parametrium felt free, and perrectal examination, no nodularity felt in POD, and rectal mucosa was normal. Summary, a 48-year-old postmenopausal woman who is para 3 light 3 with previous 3 normal vaginal deliveries presented with chief complaints of abdominal distension for past 6 months. On examination, a hard abdominopelvic mass of 16 week size gravid uterus with restricted mobility with no ascites, probably an adnexal mass for evaluation. So I'd like to offer a differential diagnosis for this patient, which could be a malignant ovarian mass or benign ovarian mass, fibroid uterus, broad ligament fibroid, or tuberculosis.
Nice presentation, Dr. Dharani. Well presented. Sangeeta Madam, would you like to start the discussion? Dr. Sangeeta Arya, ma'am.
Hello, ma'am. Good evening. Good evening, everyone.
Welcome, madam.
Just now, I have heard the case. I have one patient more is left. I'll finish my work and will join. Till then, you can ask questions, ma'am. Meena, ma'am.
Yes. From your clinical case presentation, can you elaborate? Start from the first slide. Go back, Dharani.
Yes.
Hello, Padma, ma'am. Good evening.
Yeah, good evening. Good evening, Meena. How are you?
Fine, madam. Let's go back. So, from the history, can you tell any risk factors? You were telling about benign ovarian mass, malignant ovarian mass. So, first, you put us malignant ovarian mass as your differential diagnosis. From the history, can you tell me what are the positive findings to suggest malignant ovarian mass?
Ma'am, she's a postmenopausal lady.
Yeah, from the first slide, you can tell. First slide. Postmenopausal, okay. Then?
She had sudden onset of abdominal distension.
Okay.
She had a history of loss of weight, which is significant 12 kgs in past 3 months.
Hmm.
And that's all from the history, ma'am. On from the examination point, she had the mass was felt hard in consistency, and the mobility was all restricted in all directions. It's almost like fixed mass, which points more towards mass.
Okay. So, for benign ovarian, can you tell for some more points?
The margins were irregular.
Clinically, how will you differentiate the benign and the malignant mass? That's what matters.
Yeah. Clinically, how do you differentiate benign and malignant?
Benign mass, usually it will be unilateral and it will be cystic or firm in consistency, and margins will be regular with mobility in side to side direction. Mobility will be present in case of ovarian mass. In case of there may be ascites in case of malignant mass, and with the margins irregular.
Just tell the benign first. No, you told unilateral. Then, like that, 2.5 points you just.
In case of benign mass, it will be unilateral. Margins are regular. Consistency will be soft to firm, and cystic in consistency.
Consistency, what you told first was correct. Cystic, solid usually will be solid and hard will be in malignant.
Malignancy.
Then you were telling about mobility. Mobility is Side to side and
Side to side mobility will be present in case of ovarian mass of benign type.
And then there will be no other associated symptoms, bowel or
Bowel bladder symptoms will be bowel bladder habits should be normal.
you were telling about groove sign.
Yes, ma'am. Groove sign is the mass can be felt separate when we do a bimanual examination. The mass will be felt separately from the uterus, like a groove in between the mass and the uterus mass. It will seen in case of an adnexal mass and it differentiates that it is not arising from the uterus, and it's an adnexal mass.
Dr. Dharini, you have told that uterus is felt separately. You are feeling the groove. Where is the uterus and what is the position of mass? It is anterior or posterior to uterus?
It is felt posterior to the uterus, ma'am.
That means it is coming from left to right side. You are feeling in both the iliac fossas,
Yes.
right? It is a big mass.
Yes,
Then
ma'am.
you are feeling it anteriorly? Uterus? Where could you feel the uterus?
Uterus is anterior and the mass fell posterior to the uterus. Through the bilateral forniceous fullness was there, and through the fornice the mass is felt, ma'am.
Okay. What is the size of the uterus?
Uterus is bulky, ma'am. Just bulky.
Bulky. Okay. And your patient is obese, or what is the BMI of your patient?
23, ma'am. BMI of the
23. Right. Thank you. Please go ahead. Go ahead. Malini ma'am, please go ahead.
What is the normal BMI, Dharini?
18.5 to 25 kilogram per meter square, ma'am.
18.5 to 22.9. 23 to 24.9 is overweight.
Yes.
Okay, more than 25 is obese now. Okay, so from your history, what are the risk factors you could identify? Risk factors for ovarian. Go back with your history.
Postmenopausal age factor.
That you told, don't keep repeating. That is one thing. Then
No other risk factor she had from her history, ma'am. No.
So what are the risk factors for ovarian?
Early menarche, late menopause, nulliparity, infertility, less time of breastfeeding the child, family history of ovarian or endometrial or breast cancer or colon cancer running in the family.
Little slower, Dharini. So you were telling about family history.
Yes, ma'am.
Of colon cancer, endometrial and ovarian cancer. What is that called as?
Lynch syndrome, ma'am.
Okay. Also called as?
Ma'am?
Also, what is HNPCC?
Hereditary non-polyposis colon cancer.
Okay, you remember CEO, colon, endometrial and ovarian cancer. So in the family history, what you have told actually? In your family history of this 48 years old woman.
No history of endometrial or colon or breast cancers running in the family members.
So you have ruled out family members. Okay, so there is no family history. If there is a family history, what do you expect in your history when these women will present?
At the earliest age group, ma'am, at least 10 years from the normal age people.
Very nice. 10 years, right.
10 years earlier. So, what other things you want to know in your family history? Any mutations which can contribute to ovarian cancer?
BRCA1, BRCA2 mutations we have to know about whether any family members are having. And
BRCA1, when do they present? BRCA1 cancers.
35 to 40 years of age.
Okay, and BRCA2?
40 to 45 years of age group.
The chromosome? So BRCA1 and CA2?
13 to 12, 17.
Chromosome 13, ma'am.
BRCA1 is chromosome 17, BRCA2 is chromosome 13. Anything else? Risk factors?
How do you correlate the
History of-
family history of BRCA1, like if in the first family member and the second family members, how the rate is increased? Incidence of cancer in this female will increase. Is there any correlation?
BRCA1, in case BRCA1, there is a 40% risk of ovarian cancer. In BRCA2, there is 20% risk of ovarian cancers.
And in the Lynch syndrome?
10%. In Lynch syndrome, the most common is endometrial. After colon, it's endometrial.
If the patient is having second degree relative positive for breast cancer, is she having a high risk in this at present?
Yes, ma'am. We have to rule out.
You have to rule out. Right. Okay.
Now, what
Any
other
role
risk
of-
factors you have seen?
Ma'am?
What other risk factors? There is a entity called talc on the perineum. Other things you have told, nulliparity, breastfeeding is not there. So in your case, so she is not a nulliparous. She has breastfed the babies, all 3 babies.
Yes, ma'am.
What are the protective factors? Can you elaborate on protective factors for ovarian?
Breastfeeding, sterilization, history of self-injectomy done, then history of any OCP intake.
Yeah, very good. So OCP intake, it's called chemoprophylaxis. So that history, have you taken any
Yes,
history
ma'am.
of OCP? Yeah. So chemoprophylaxis. What is the theory which is common behind CA ovary?
Ma'am, I couldn't get you. Ma'am.
Theory for CA ovary, malignant ovarian.
Ma'am,
What hypothesis for?
Incessant ovulation.
incessant ovulation and
By Patella. Patella's incessant ovulation. This is one of the commonest question which is asked. Theory for malignant ovarian is incessant ovulation by Patella. So you have told about chemoprophylaxis by oral contraceptive pills,
How
tubal
long she has
sterilization,
to,
also add hysterectomy. Okay, as a protective factor. So if they have babies and if they have breastfed, the chance of having a ovarian malignancy is less. Now, the risk factors, you add talc on the perineum as well. Okay, industrial carcinogen. Now, in your history, you were telling about benign and malignant. Thinking in terms of benign, what are the investigations you want to do?
First, I like to have an ultrasound done, ma'am. Transvaginal along with transabdominal ultrasound. Ultrasound, it may give some clue ideas on whether the mass is benign or malignant. Based on the ultrasound findings, I will.
What are the clues you get from your ultrasound?
In the ultrasound, if it's in case of benign, it may be unilocular, anechoic, thin wall cyst, unilateral cyst with thin septa less than 3 mm or without any solid components or
4 mm.
projections.
Okay.
In case of malignant mass, it will be bilateral, multilocular, more than size may be more than 10 centimeters with solid areas and papillary projections with ascites. On Doppler, there may be increased color flow with the low risk.
Madam, அழகா உனக்கு பாயிண்ட் எடுத்து கொடுத்துட்டே இருக்காங்க பின்னாடில இருந்து. டாப்லர்ல increased flow, that is also important. Okay, what are the acute events you note in a case of ovarian? Acute events.
Torsion, rupture, hemorrhage into the cyst, infection.
Okay, main thing is hemorrhage, rupture and torsion. If there is a torsion, what is the ultrasound finding which is characteristic of ovarian?
Ring of fire.
See, when there is twisting of the pedicle, what is called that?
Whirl sign.
Yeah, whirlpool sign. Washing machine இருக்கு இல்லையா? Whirlpool washing machine ஒன்னு இருந்தது முன்னாடி. So whirlpool sign that madam was telling, no, there is torsion க்கு whirlpool sign. These things can be commonly asked in your exam. Okay. So have you heard about RMI score?
Yes, ma'am. Risk of malignancy index.
So what are the criteria which is there in RMI score?
Ma'am, it's based on the ultrasound features and menopausal status of the women and CA 125 level, ma'am.
In ultrasound, what are the features? 5 features.
Ascites, solid areas, multilocularity, malignant signs of malignant metastasis, and then bilateral.
Madam, alaga eduthu kuduthite irukanga. US map. Okay. So that is very important. These 5 features. Premenopausal ke enna score, postmenopausal ke enna score.
Premenopausal scores 1, ma'am, and postmenopausal is 3. Into
Okay.
CA 125 levels.
Normal CA 125 is?
For premenopausal women, it's more than 200, and for postmenopausal, more than 35 is abnormal.
Okay. So in this, if you have a score beyond this, you say it is malignant or malignant features.
200, ma'am. In RMA index, it's more than 200. We have to refer to gynecologist for due to increased risk of malignancy, high risk of malignancy.
So previously they were saying less than 25, 25 to 200, more than 200 or 250. You refer the patient to oncology center. Otherwise, gynecologists can do in the own center. Okay. So benign, if this comes as benign, okay, 16 centimeter mass. You have all the criteria.
Excuse
for
me.
benign.
I want to
40
ask
years.
what is. Can I interrupt, please?
Yes, yes, madam.
What is RMI 4 scoring?
Ma'am, assessment of neoplasia in Adnexal mass score, ma'am.
RMI 4, how is it different from RMI 1, 2, and 3?
In RMI 1, the score of 0 is given if there is no features in the ultrasound, ma'am. If anything multiplied by 0 is 0, so RMI 1 came, which gave the score as 1 for one feature of ultrasound is present.
Okay, they have added the size of the tumor also.
In RMI 4,
earlier it was not.
Yes, ma'am.
Less than 7 centimeters or more than 7? Okay, Meena ma'am, please go ahead.
So this comes as a benign. How do you want to go about?
For this patient, if it comes as a benign, since she's a postmenopausal lady, we can do total abdominal cystectomy or total laparoscopic cystectomy with a bilateral salpingo-oophorectomy.
So generally benign, you usually don't go for a major removal, but indicating the age and completed family in our country, patient may be lost for follow-up, you do a complete surgery. So imagine this woman comes at 25 years,
Okay.
not born child and not had a pregnancy. So what is your management for a benign mass? Young age women.
Before proceeding with surgery, I would like to offer investigations with ultrasound and MRI. If I suspect any malignant features, I proceed with laparotomy and proceed, ma'am. With midline laparotomy incision, I'll open up the abdomen and explore the abdomen for any findings first in the pelvis, and then starting from the cecum, I'll proceed in Kefauver way and I inspect all the parts for any signs of malignancy, and I would like to take ascitic fluid for analysis. If ascitic fluid is not there, peritoneal washings will be taken, ma'am. Then unilateral salpingo-oophorectomy can be done and can be sent for frozen section. If it comes to be benign, I'll that's unilateral salpingo-oophorectomy alone can be done, ma'am. If it comes to be malignant, fertility sparing surgery can be offered to the patient based on the frozen section.
So usually 25 years, you have to do 2 tumor markers. I was expecting that in your investigation. So what tumor markers you do before doing a surgery? Usually you go for a minimal invasive surgery, not a open surgery if you're suspecting a benign. So what are the tumor markers in the reproductive age group you have to do?
Germ cell tumor markers we have to do like AFP, LDH and beta HCG.
Any
So
other
you were telling
specific?
germ cell tumor markers. எந்ததுல இருக்கும்?
Dysgerminoma, in dysgerminoma, LDH will be elevated. For yolk sac tumor, AFP can be seen. Like embryonal carcinoma, beta HCG, and choriocarcinoma, beta HCG. And
So those things you have to do before planning a surgery. Also include PLAP, placental alkaline phosphatase. Okay. So now coming to, you have done the tumor markers, you have to plan and do a minimal invasive surgery. Okay. So you may do so if she's a Bharatanatyam dancer, she doesn't want a scar. You're saying midline laparotomy. So she says, I want to have a bikini scar. You have to think in terms of conservation. Nowadays, the women are very choosy. You cannot say a very big scar. Minimally invasive surgery, you can just visualize and then you may remove in back. Okay.
Dr. Dharini, I want to ask, like we are running very fast. I want to ask about this marker, tumor markers. Do you do 19.9 marker and HE4 marker? Why are they specific? Why sometimes we have to go for it?
HE4 has more specificity towards early stage ovarian cancer compared with CA125, ma'am.
No.
We are routinely not doing that.
What is the best thing that in the 25 years female we are going to do the laparotomy or doing minimally invasive surgery we want? So HE4 will differentiate between which cancer from the ovarian cancer, which is the most common found in 25 years old lady. The other confusion, the other benign lesion. That is the endometrioma. When the endometrioma is in a healing phase, then many times we get confusion that it may be it is showing papillary, and it is sometimes thick wall lesions. Then this can be used. And 19.9, when we have to use that, when we have got a confusion of CA ovary with the other one, which cancers specifically?
Pancreatic cancer.
GI cancers.
GI cancer.
Right. Okay. Over to you, Dr. Meena.
So the two main tumor markers will be CA19-9 and HE4 for elderly women, especially. Young women, don't forget alpha fetoprotein, beta HCG, LDH.
Yes, basically rule out germ cell tumor. Yes.
Germ cell tumors, you can go for a conservative surgery. Okay.
Okay.
So you were telling staging, similar to staging for a benign tumor, you can go just do a salpingo oophorectomy, or you can just remove only the ovary or the cyst if it is present. Okay.
Okay.
So coming to your symptoms in benign, what is your symptom?
Most of the patient will be mostly asymptomatic. It may be incidentally detected on ultrasound done for some other cause, ma'am. If at all she is symptomatic, it may be like she may present as acute abdomen because of torsion or rupture or hemorrhage. Otherwise, she may have she may feel because of large size of the mass may be felt abdomen like bloating sensation, nausea, vomiting. Other vague symptoms like she may have, and she also may have pressure because of pressure effect, urinary retention, in frequent micturition or constipation like that.
Okay, well answered. And coming to your signs in benign, what are the signs you look for?
In case of benign mass, the mass will be usually cystic in consistency with regular borders and mostly unilateral tumor with mobility present in side to side direction. No nodularity, no ascites.
And there will not be any transmission of the
mobility to the cervix. Transmitter mobility to the cervix will be absent.
Okay. Then you have done ultrasound. You have found. How do you follow up? You have done the surgery. How do you follow up?
After malignant mass, ma'am.
Yeah.
No, benign. We are going with the benign first. You told the ultrasound, you have done tumor markers, you have done the routine investigations for doing a surgery, ECG, X-ray, cardiac opinion, everything you have obtained, you have done a surgery. Minimally invasive surgery. Aruna, can you, Dr. Aruna, can you close your mic? Sahiti, can you close? Aruna? Sahiti, can you? Okay. So can you just talk about what are the usual routine histopathological examination findings you get in a benign mass?
It's
Or can you just simply tell what are the classification of a benign ovarian mass?
it is benign functional cyst like corpus luteal cyst or theca lutein cyst or a functional follicular cyst, then endometrioma, tubo-ovarian abscess, hydrosalpinx.
So you can tell about serous cystadenoma, mucinous cystadenoma, they are all benign, no?
Yes.
Just tell those also. So you told about functional classification, functional cyst, thecoma, you were telling about corpus luteal cyst. Then also talk about your serous cystadenoma, mucinous cystadenoma, then
Fibroma, thecoma.
yeah. So can you tell what is Meek syndrome and pseudo Meek syndrome?
Meek syndrome is triad of ascites with right-sided pleural effusion with with the ovarian solid tumor like fibroma. Pseudo-Meek syndrome is ascites and pleural effusion with the solid mass other than the ovarian cause like fibroid.
So you should know about both what you have told is correct. So Meeks and pseudo Meek syndrome. Now coming to your if it comes as borderline ovarian tumor, what will be your management? You have opened up or done a surgery, minimally invasive surgery, and it has come as borderline ovarian tumor. She is now 30 years old. What you would like to do?
If she is wishing for, if she wants the future fertility to be preserved, I would do a fertility preserving surgery with unilateral salpingo-oophorectomy, ma'am. With if nodes are palpable, I'll also do lymphadenectomy with infracolicomantectomy with peritoneal biopsies. If she's not wishing for future fertility and her family is completed, I'll do total abdominal hysterectomy with bilateral salpingo-oophorectomy with lymphadenectomy.
Okay. Usually you wait for her to complete the family. Once she has completed the family, you go and proceed to do a staging laparotomy, total abdominal hysterectomy with the bilateral salpingo-oophorectomy. If you have done unilateral salpingo-oophorectomy, try to complete the surgery early once she has completed the family. Sangeeta madam, would you like to ask questions?
Yes, but Dr. Dharini, always you have to give the patient should get the opinion about conserving her uterus. Every time we don't want to go for total abdominal hysterectomy. If it is a benign lesion, she is only 45. If she wants to conserve her uterus, then you have to give her option about this also, right? And we have to be very clear about it is a benign tumor or it can be a cancerous tumor. Then we have to go do the management accordingly. Then you have to go, right? And in the case sheet, you have to write before performing the surgery. If you are doing the minimal invasive surgery and you are thinking of the dermoid cyst, you can conserve the ovary in the dermoid cyst if it is a mature teratoma.
Yes, ma'am, we can conserve.
You want to conserve. Otherwise, it is very flattened ovary. It's a big ovary. Sometimes surgeons do think that they can chop off the ovary, whole of the ovary. But in these cases, we can conserve the ovary also. The rest tissue we can conserve. Is it necessary to stitch the ovary? We have removed the big cyst from the ovary, and the ovary has come like the structure is open like this only. So we have to stitch the ovary back, or we can leave it as such.
Ma'am, we can leave it also.
We can leave it as
not compulsory that we have to stitch the ovary back.
Right. What is the final diagnosis in your patient, 43 years old lady?
Ma'am,
This is a real case or you have
yes, ma'am.
found it?
It's a real case, ma'am. We have her MRI came to be bilateral solid cystic ovarian mass, ma'am, with bilateral ovarian cyst. And we done oligoscopy and colonoscopy, and it was negative. So we proceeded with laparotomy and proceed. And the frozen section came to be high grade serous carcinoma.
High grade serous carcinoma. What are the incidence of high grade serous carcinoma in a, if we are thinking it to be a benign serous cystadenoma? How many chances of being malignant in these cases?
High grade carcinoma are more common, ma'am, than benign.
In a serous cystadenoma, if we find out to be, it's like in our ultrasound finding it, I gave it as a serous cystadenoma. How many chances of being malignant are there in these cases? Serous cystadenoma, simple serous cystadenoma. What we have to told the patient that we are going for the surgery in a benign tumor. That is, we are thinking that it should be a serous cystadenoma. Still, some percentage of female can have a cancerous lesion in that. How many percentage of patients?
80%.
Around 10%. If you are thinking it to be a serous cystadenoma, plain serous cystadenoma. We have to write, we have to think of things, we have to tell the patient that it can be a reason, and later on we have to go for the extensive surgeries.
Okay.
What is neoadjuvant chemotherapy?
Neoadjuvant chemotherapy is it is done in case of advanced carcinoma, where the chemotherapy is given for 3 cycles, followed by interval cytoreduction, and then followed by again chemotherapy for 3 cycles, ma'am.
Have you given this chemotherapy in your patient, this patient?
No, ma'am.
You haven't considered her. Ideally, you should have considered. What is optimal cytoreductive surgery?
Optimal cytoreductive surgery is that residual tumor mass should be less than 1 centimeter, ma'am. Other than the resected mass should be residual resected tumor mass should be less than 1 centimeter.
Very good, very good. And post-op chemotherapy?
Yes, ma'am.
Have you given?
Yes, ma'am. We have given.
Which chemo you have given in this patient?
Ma'am, carboplatin with paclitaxel, ma'am.
Paclitaxel. Okay.
She's currently on chemotherapy.
Okay. Side effects of chemotherapy?
Myelosuppression, liver toxicity, renal failure, nephrotoxicity.
Just need to tell the name of the drug and the chemotherapy effect, side effect profile.
Myelosuppression is seen in case of carboplatin, ma'am. Especially thrombocytopenia will be seen. And for paclitaxel, like peripheral neuropathy, nephrotoxicity, and peripheral neuropathy.
So nephrotoxicity is more with cisplatin than your carboplatin. Okay, you prefer more of carboplatin and paclitaxel. Okay, so in your case, you have told about it's a
high grade.
What is that? High grade
serous carcinoma, ma'am.
Okay, so serous cystadenoma is benign. So your case is serous cystadenocarcinoma, right? So you have given chemotherapy also.
Yes, ma'am.
So what is the prognosis of the disease? Why have you given chemotherapy? Have you had a discussion with the tumor board?
Yes, ma'am. After surgery, the sensitivity to chemotherapy also is increased. And if it is a high-grade tumor, we have to give chemotherapy. And 5-year survival rate is 60%.
Okay. So if it was a BRCA1 positive, what you would have done? You told there is a high risk of malignancy in a young age. What you would have done to that patient?
I'll counsel her like after completion of family and at around 35 to 40 years of age, bilateral salpingo-oophorectomy has to be done.
That is called as RRBSO. What is it?
Prophylactic risk reduction salpingo-oophorectomy.
Risk reducing bilateral salpingo-oophorectomy. When do you do when the woman is BRCA2 positive?
At 5 years later than the BRCA one, like 40 years of age.
Okay. And what other things like CA ovary, named syndromes you have? Told about Lynch syndrome. Any other syndromes?
Peutz Jeghers syndrome.
What are there in that?
It also includes colon polyps along with ovarian CA.
Okay. Can you elaborate on the staging, what you would have done for this patient?
We have,
Staging.
ma'am.
Steps of staging laparotomy.
We made a midline laparotomy incision and we took peritoneal washings we have taken for cytology and we explored the abdomen for the any signs of meds. Then we proceeded with bilateral salpingo-oophorectomy and we sent it for frozen section. It came to me high-grade serous carcinoma, so we proceeded with staging. Total abdominal hysterectomy was done and then pelvic and parietic lymphadenectomy was done with infracoelicomentectomy, ma'am.
Hello, Dharni.
Hello, ma'am. Can you hear me?
So, yes, I can hear you. So you do staging in a particular fashion, no? Starting from the right side, the ascending colon.
Yes, ma'am.
Why do you do that way?
In order not to miss anything.
Because the flow of lymphatics is that way. It happens.
Direction.
Yeah. So you do infracoelicomentectomy and peritoneal biopsies.
Yes, ma'am.
So what is important in that?
To stage the disease, ma'am.
Yeah. So it is a surgical staging. Unlike your CA cervix, where you say CA cervix is clinical staging, CA ovary is surgical staging. So can you elaborate on the staging what we are doing right now? We go which year and staging. Have you read staging of CA ovary?
Ma'am.
Yeah. Can you just say if you are
Stage 1 is stage 1A. It is confined to one ovary or one fallopian tube. Stage 1B is bilateral ovaries and bilateral fallopian tubes are involved. Stage 1C is either one or both ovaries with the following, like 1C1 surgical spill is present, 1C2 the capsule has ruptured before the surgery, and 1C3 is ascitic fluid positive for malignant cells. And stage 2, the disease has spread to the pelvic organs, like stage 2A is spread to uterus with other either to the fallopian tube or to the ovary. Stage 2B is other pelvic peritoneal involvement. Stage 3 is extra pelvic peritoneal involvement, like 3A is lymph nodal involvement with 3A1 less than 1 centimeter of node and 3A2 is more than 1 centimeter of node. 3B is microscopic involvement of the extrapelvic peritoneum, and 3C is macroscopic involvement. Like one is less than 2 centimeter and the 2 is more than 2 centimeter. And stage 4A is pleural effusion and stage 4B is distant metastasis. Stage 3 it also include only the capsules of the liver or spleen, like Glissen's capsule, and the parenchymal involvement of the liver and spleen will come under 4B.
okay. Sangeeta ma'am, you would like to ask questions?
We have to take another case also, no, ma'am?
Yes, ma'am.
You have one more case?
Yes, ma'am. One more case is there.
Yeah. You can present
Because
that.
it's already 6:30. She can
Yeah,
present. Very good.
Yeah.
You have done good.
You have answered everything, Dharani. Excellent preparation. Keep it up. All the best for your exams.
Thanks.
Good evening, ma'ams. Shall I start my case, ma'am?
Yes, pa.
Yes, please.
Ma'am, Mrs. X, a 20-year-old residing from Shivagangai, student, a second-year college, unmarried, belongs to lower middle-class socioeconomic status according to modified Kupusamy scale. She came with complaints of diffuse abdominal pain for past 1 year and complaints of abdominal distension for past 2 weeks. History of presenting illness, the patient was apparently normal 1 year back, and she had complaints of abdominal distension associated with lower abdominal heaviness, insidious onset, gradually progressive in nature. Complaints of abdominal pain, the insidious in onset, dull aching pain in midline, below umbilicus, aggravated on doing regular physical activity and relieved on taking rest, not radiating pain. And she also had complaints of frequent belching and early feeling of satiety for past 2 weeks. So no history of any heavy menstrual bleeding or dysmenorrhea, no history of discharge per vagina, no history of any urinary frequency, urgency, retention and dysuria, no history of constipation, loose stools or deadened stools, no history of nausea, vomiting, bloating sensation, no history of weight loss or loss of appetite, no history of fever, evening rise in temperature, cough with expectoration, no history of any leg swelling, shortness of breath, chest pain and palpitation, no history of yellowish discoloration of skin and eyes. So menstrual history, she attended menarche at 11 years of age. She had regular cycles, 20 to 38 days, lasting for 3 to 4 days flow with no dysmenorrhea or clots passage. Marital history, she is unmarried and she is not sexually active. So medical history, she is not a known case of diabetes mellitus, hypertension, thyroid disorders, bronchial asthma, epilepsy, tuberculosis and CAD. Surgical history, no significant surgical history. Family history, no history of tuberculosis, thyroid disorders, bronchial asthma, no history of breast, colon, endometrial or ovarian malignancy in family. Personal history, mixed diet, normal sleep and appetite, normal bowel and bladder habits. General examination, she is moderately built and nourished, with adequate hydration, no pallor, pedal edema, icterus and cyanosis, no palpable lymph nodes. Her height is 148 centimeter, weight is 66 kg, BMI was 30.1 kg per meter squared, which belongs to class 1 obesity. Her vitals are her vitals are normal. BP was about 120 or 70, right arm in sitting position. Pulse rate was 86 per minute. Respiratory rate was 18 per minute. SpO2 was 99% on room hair. Systemic examination was everything was normal. CBS was S1, S2 hurt. Bilateral R entry is present. CNS, no focal neurological deficit seen. Breast, that is normal, no soft, no palpable lump. Thyroid is not enlarged and spine normal. So in parabdominal examination, inspection, the abdomen was uniformly distended. Skin over the abdomen appears stretched and skinny. Umbilicus mid position inverted. All quadrants move equally with respiration, and there is no scars, sinuses, dilated veins, pulsation, hernial orifices free. And palpation or the above inspectory findings has been confirmed. On superficial palpation, the abdomen is uniformly distended, soft. There is no localized raise in temperature, no guarding, no rigidity, and non-tender. On deep palpation, an abdominopelvic mass, abdominal mass corresponding to gravid uterus of 20 weeks occupying in suprapubic region, umbilical and in left iliac fossa. It was a smooth surface with firm consistency with regular borders, mobile and non-tender, lower border felt, no organomegaly. Percussion, there is a dull note on the bilateral flanks and shifting dullness positive. Auscultation, bowel sounds present, no venous hum or bruit. Pelvic examination, local examination, pubic hair seen, plus labia majora and minora appears normal, urethral meatus appears normal. So generally we should not do any perspiculum or paravaginal examination for an unmarried girl. This was done under anesthesia intraoperatively. So perspiculum examination, cervix and vagina are healthy, no abnormal discharge or bleeding. Bimanual examination, cervix was pointing downwards, a large abdominopelvic mass of 20 week size, which was soft, firm in consistency with regular surface, mobile and absent transmitted mobility with left fonial fullness seen, groove same plus, and there is no nodularity felt in POD. Rectovaginal examination, the rectal mucosa free, bilateral parametry free, no nodularity in AOD. So summary, a 20-year-old obese student, unmarried with irregular cycles, with diffuse abdominal pain for 1 year, and abdominal distension for 2 weeks presented with abdominopelvic mass, corresponds to 20 weeks occupying suprapubic, umbilical and left iliac fossa. Smooth surface with firm consistency with regular borders, mobile and shifting dullness positive with left fonial fullness and bruising. On bimanual examination positive, came for further management. So provisional diagnosis, a 20-year-old unmarried woman with abdominopelvic mass, probably an Adnexal mass.
Any other differential diagnosis you would like to give?
Differential diagnosis, the first thing would be an pregnancy. benign ovarian tumors, malignant ovarian tumors, endometriomas, tubovarian abscess, non-gynecological conditions are mesenteric cyst, pelvic kidney.
What about full bladder? If it was a full bladder, how
Yes,
would you
ma'am.
rule out?
Over distended bladder will also be in one of the differential diagnoses, ma'am.
So you have ruled out pregnancy?
Ma'am?
You have done a pregnancy test
Yes, ma'am. We
also?
have done first. Initially, we have done a urine pregnancy test, which came to us negative.
And you have managed this case, or is she in the ward?
Like she got discharged, ma'am. But we managed to stay.
Operated on her?
Yes, ma'am.
So what is the finding on surgery?
Ma'am?
Surgical finding.
So, intra findings, there was an minimal ascites, ma'am, around 500 ml fluid collection. And we could see a unilateral mass arising from this left ovary, which was smooth, regular borders with firm and consistency, which points more towards intraoperatively, which points more towards benign. But to confirm it, we have done an unilateral salpingo-oophorectomy and we have sent for a frozen section, and it came out to be a benign sex stromal cell tumor.
I have so questions for you, Dr. Kaushalya.
Yes, ma'am.
You have told me earlier that it is a 20-week size mass, right? And you could feel the groove sign, and it is the left-sided ovarian mass. And please come back to your findings per abdominal and yes. Here you have said that it is uniformly distended, right? Palpation, abdominopelvic mass corresponding to this size, and umbilical and left leg fossa surface with regular, non-tender felt. Okay, ठीक है. Next please. Next slide.
Percussion, ma'am.
Percussion, okay. And somewhere you have said that there was a shifting dullness was positive.
Yes, ma'am.
What does it signify?
It signifies there is a minimal ascites of about 500 ml.
You will get shifting dullness and 500 ml water inside the peritoneum also?
Not only ascites, ma'am, even
in a 20-week size mass with 500 ml fluid inside the peritoneal cavity, will it be possible?
More than
shifting dullness. Do you think have you ever seen what is shifting dullness?
Yes, ma'am.
Okay. I don't think so you will get positive sign in 500 ml fluid you are getting in the peritoneal cavity, right? The next slide. Next slide. Okay, right. Why you have done? What condition you have you had in your mind to do the per speculum examination in this patient? What extra? What good finding you will get by the per speculum examination, and you won't get in the per rectal examination in an unmarried female? What extra finding you want to know? That you have given anesthesia to this patient also, and you have done the per speculum examination. These findings can be correlated in the per rectal examination also. This is an unnecessary examination. I think so. What Dr. Meena is saying, I don't know, but according to me, it is an unnecessary.
Even I thought so. Madam Sangeeta ma'am, even I thought, because in an unmarried girl who's not sexually active, having a cervical and vaginal examination is not needed, and a per rectal examination would have helped. No need to do a per speculum examination without consent under anesthesia, which is not pardonable.
This is totally unwanted, unnecessary investigation you have done in this patient. Next, please. Again, absent transmitted mobility. Okay, done. And what about the phonesis fullness? For which phonesis?
Left side phoneal fullness present, ma'am.
Left-sided. And what about right?
Right side, minimal phonesis. It is not like full fullness was present, ma'am.
Right side also,
you
haven't examined your patient normally. How could you feel? How could you give the comment on the phoneal fullness? You have given it on per rectal examination, or the per-vaginal examination?
This is written as bimanual examination, madam. So that means I think Kausalya, is it per-vaginal examination?
It's a bimanual examination, ma'am.
That is what?
Bimanual per rectal, right?
Yes, ma'am.
And it was 20 weeks and she is morbidly obese. I think BMI is 24 around. Chalo, theek hai. We could understand that it is a 20-week size. It is filling the full pelvic cavity, right?
Yes,
This
ma'am.
mass is filling the 20-week size is a big size. Mass is there. You could feel it like the whole pelvis is full of mass. Why are you saying that left is full, left was full and right was empty? If it is of 20-week size, we can think, yeah, this is both the fornices were full with this mass, right? Next, please. Because of that is okay. That is okay. Next, please. What is groove sign? Everywhere you have told us that is there was a groove sign. What is the groove sign? And where could you feel this groove sign in your patient? With a unmarried female, 20-week size, suprapubic lump extending up to umbilicus, where have you felt this groove sign?
Ma'am, groove sign is a pelvic examination where we'll see a groove between
the per rectal examination.
Ma'am?
In the per rectal examination, you have felt this mass?
No, ma'am. Bimanual examination only, ma'am.
Like per vaginal?
Yes, ma'am.
After the per speculum examination, you have done the per vaginal examination also?
Bimanual, yes, ma'am.
Okay. Please correct it by your, whoever is your guide. I don't think so. This should be mentioned in your cases everywhere.
In your
Basically,
case,
we
you
mentioned,
have to do
yes.
a rectal examination and not a bimanual examination. She is unmarried, not sexually active, and you have done an examination under anesthesia, introduced a speculum without consent, and the per-vaginal examination is not at all a mandate. Just a per-abdominal examination and a trans-abdominal ultrasound would have picked the investigations.
Where basically we use this groove sign. Have you ever have you ever read about the broad ligament fibroid? It is true and false.
Yes, ma'am. Also in subserosal fibroid and broad ligament fibroid, groove sign will be present.
In which fibroid? Groove sign will be present? Whichever is originating from the uterus.
I couldn't get you, ma'am.
Whichever mass is originating from the uterus, lateral side of the uterus, and it is extending into the broad ligament. Then you will feel the groove sign.
Yes,
Everywhere
ma'am.
you can't feel the groove sign. It is very like we don't mention it everywhere. Okay. Now please come to the diagnosis. Meena ma'am, please take up the case.
Yeah, so your diagnosis is the abdominopelvic mass and you have given differential diagnosis. Can you move on with the next slide?
That's all, ma'am.
No, the previous one, DDs. Differential diagnosis, yeah. So if it was a endometrioma or some benign ovarian, imagine it is a benign ovarian. You have removed the cyst. You want to prevent retorsion. What you will do? Extra step apart from removing the cyst. Anything else?
We will do a ophoropexy, ma'am. We'll fix the ovarian ligament to the round ligament, ma'am.
So there is a technique to do laparoscopically. Name of the technique?
Hot dog in a bun technique, ma'am.
Excellent. So that may be expected out of you because it is a young girl. If you have removed the cyst, you may require to do a ophoropexy, that is hot dog in a bun appearance. And if it is a endometrioma, what you would have done?
I would have done a cystectomy, ma'am. Endometrial cystectomy and intrapathologisis.
Okay. Now you were telling about your diagnosis, no, after surgery.
Yes,
can you talk more about the diagnosis, what you have received?
So, ma'am, sex cord stromal cell tumor, it constitutes of about 8 to 10% of all ovarian malignancies. So we have this pure sex cord stromal cell tumors, pure stromal cell tumors, and mixed sex cord stromal cell tumors. In pure sex cord, in pure sex cord, we have this granular cell tumor, adult and juvenile type, and the Adnexal tumor. Whereas sex cord tumor with malignant transformation, and in pure stromal cell tumor, we have the sarcoma, fibroma, sclerosing stromal cell tumor, signaling stromal cell tumor, and setoli cell tumor. In mixed variety, we have the sex cord stromal cell tumor, setoli cell tumor, and
Dr. Kaushalya, why you have written pelvic kidney in the differential diagnosis when you could get the lump of 20-week size? Mesenteric cyst, we can understand that it can be of 20-week size and you're not able to get the lower border of that lump, right? If ovarian abscess, we can, yes, it is a okay diagnosis. Endometriomas can be there, but pelvic kidney, usually it is very small, not of 20-week size, I think. Which is the most common benign tumor found in adolescent females?
Most common benign tumor is mature cystic teratoma.
How it is diagnosed?
Ultrasound, I mean, ultrasound. There is no
Yes, yes.
markers for
Please
that.
don't get disheartened. Please carry on. This happens many a times in the cases. You have to be very punctual, very particular about everything. Yes, now tell. Mature cystic teratoma, how do you diagnose? What specific findings do you get? In the ultrasound, yes, mature cystic teratoma.
We'll have this presence of the teeth, hair, bones, and the protuberance known as Rokitansky protuberance.
Yes. All the mature 3 layers, the contents you can find out in the mature teratoma. What is the specific finding related to? Because the mature teratoma is usually having the fat inside it.
Yes,
so usually it gives what specific clinical sign about the mature teratoma in a clinical examination while you are doing the perabdominal or the pervaginal examination. Because it is having a fat inside, it is usually floating type. So isko whenever we do the pervaginal examination of PA, it is felt anteriorly to the uterus. That is why it is called as the anterior tumor. This can be a specific finding in the mature teratoma. How many chances are there in the mature teratoma to come as the cancerous one? Immature one or the cancerous one? How many chances are there? It can be malignant?
Less than 1%.
No, more than. Right. You have to read out. You have to find out these things, right? And how will you manage the mature teratoma in this 25 years old female unmarried?
So I'll do a unilateral cystectomy, ma'am.
You will conserve the ovary, the ipsilateral ovary. You will conserve the ovary.
Yes, ma'am. The other side ovary, I'll conserve it.
Conserve the ovary. What about the other cancers, other germ cell tumors?
Other germ cell tumors are desgiominoma, yolk cell tumor, embryonal carcinoma, and non-gestation chorea carcinoma.
That you have already told to ma'am, and we have already discussed the tumor markers in these patients. What other epithelial tumors you can get in the adolescent females? Again, we have already mentioned, but still you have to mention the epithelial tumors. Dr. Dharini has already told.
Yes, ma'am. Serous adenoma, mucinous cystadenoma.
Very nice. Yes.
All borderline tumors.
All the borderline tumors you can get. Right. And how did you manage your patient? It was finally what diagnosis you got in this patient?
Sex cord stromal tumor, ma'am. Benign. Sex cord stromal cell tumor, benign.
Sex cord stromal tumor. Okay. It was benign.
Yes, ma'am.
Okay. The patient is doing fine?
Yes, ma'am.
You have to work hard on the per abdominal and per vaginal examination, where to do, where not to do, and a per rectal examination.
Yes,
You
ma'am.
have to be very right. Okay, all about anything else, Nama? Kausalya, what is IOTA?
International Ovarian Analysis Group, ma'am. So we have B groups and M groups. So B groups, we have B rules, we have this unilocular cyst, solid projections less than 3 mm and multilocular cyst more than 10 centimeter with acoustic, posterior acoustic shadow and Doppler color 0 or 1. Whereas as M rules, we have this solid tumors with multilocular cyst more than 10 centimeter and multiple solid papillary projections more than 10 mm, ascites and color Doppler 3 or 4.
How do you manage a corpus luteus cyst in an adolescent female? What is the further follow-up? Is the patient is having follicular cyst or the corpus luteal cyst?
Based on the size, less than 7 centimeter, we usually go for conservative approach. If it's more than 7 centimeter, we go for an surgical procedure.
No, in an adolescent, still you can wait. You have to further follow. Why are you going to operate in that patient? You have to be cautious about the torsion of that cyst, but otherwise you will go for the conservative management also. Do you think so? Okay, you want a surgery? You want to do surgery in the corpus luteal cyst? Huh? No, you want to be more on the conservative side, right? And what is the theca luteal cyst?
Theca luteal cyst, it is usually associated with non-gestation choriocarcinoma, more than 6 centimeter in size. Secretes more of estrogen.
Usually these are seen in the pregnancy and they get resolved by themselves, or we have to do it by surgery?
They can resolve by themselves, ma'am.
Subsequently, they resolve by themselves, right? What is the decidualized endometrioma? What are the features?
Ma'am, features of
decidualizing endometrioma. What basic findings of ultrasound do you get in endometrioma?
Ground glass appearances in the ultrasound.
In the initial phase? In the initial phase? It is multiloculated, loculated, or uniloculated, or
multiloculated, ma'am. Multiloculated.
Always? No. It's not always multiloculated.
Okay.
Chalo, you have done very nice. Don't be disheartened. Go and read. That's all from my side.
Yeah, thank you, Sangeeta ma'am. So, in your case, how was your follow-up? Had you discussed this case in tumor board?
Yes, ma'am. We have discussed this case in tumor board and they have just asked us for observation.
So, how will it be your follow-up? She's only 20 years. You have removed one ovary. What is the chance of fertility?
No issues in that, ma'am.
I'm just asking you.
Ovaries, we didn't do anything, so she has all possibilities to get conceived like any other woman.
Yeah. So what is that you say, no, ovarian preservation?
Yes, ma'am.
Anything you have known about it, ovarian preservation?
Yes, ma'am. We have this established one, which is embryo preservation and oocyte preservation. Experimental ones is ovarian tissue preservation and IVF. So in an unmarried women, we go for an oocyte preservation. And also the ovarian transposition, fixing to the paracolic gutter.
So you call it as oocyte cryopreservation, which you can do if in case you suspect some malignancy. Okay.
Yes, ma'am.
And you ask her to have her pregnancy early, complete the family, and then go for completion surgery if it is going to be any other tumor. Okay. Now, what are the methods in which you can remove the specimen in case of a benign ovarian?
Okay, ma'am. Ma'am, I couldn't get you, ma'am. What was the question?
In benign ovarian mass, you're doing surgery, minimal invasive surgery. What are the methods by which you can remove the tumor outside?
By in-bag morcellation, ma'am. In-bag specimen retrieval through the main supraumbilical port, or by doing a colpotomy.
Yeah. So you can do a colpotomy in case the women wishes to avoid a bigger surgery. Colpotomy will be a best option. After aspirating, you can do a colpotomy incision and remove. Padma ma'am, your questions, ma'am.
Yeah. No, it's already is going to be 7 o'clock. So I think we had a very good discussion. Thanks to both of you, Dr. Sangeeta and Dr. Meena. Hello.
Thank you so much, ma'am.
Thank you, Meena. Have a pleasant evening.
Madam, நீங்க எங்கயோ வெளிய போயிட்டீங்க halfway through.
அதான்
You will also ask.
For patients were there and then they were just giving a trouble.
Okay. I thought you will also ask questions, ma'am. Thank you, ma'am.
Yeah, thank you.
Thank you, Dr. Sangeeta, madam. Thank you, Dr. Radhika Kauri.
Thank you, ma'am. Thank you for inviting me.
Thank you. Thank you, Kausalya. Thank you, Dharani. Thank you, Padma, madam.
Thank you, ma'am.
Thank you, Sahiti. Thank you, Sri Priya, for the platform.
Thank you.
Thanks, ma'am.
The nice weekend.